RPA PAL is sponsored by an educational grant from Amgen, and we greatly appreciate their support. Finally, be sure to check the RPA website for upcoming webinars and events. And I will now turn this over to our moderator, Dr. John Long.
All right, thank you, Amy. All right, hello and welcome to the 2020 RPA PAL Annual Forum during this era of pandemic Zoom meetings. I would like to extend a warm welcome from Texas. Hope you and your families are doing great and staying safe. First, few housekeeping items. Snacks and drink are on the house, I mean on your house. Pants are required just for the speakers. And feel free to flush because you're all muted, we don't care. Masks are mandatory and keep washing those stinky hands. All right then, let's dive in. The topic for this webinar is the voluntary payment models, KCF and CKCC. All right, perfect. So today's speakers are Jeff Gillian, who serves as a Chief Medical Officer of DaVita Kidney Care. Jeff joined DaVita in 2016 and serves as a Chief Medical Officer of Hospital Services, VP of Medical Affairs, and National Group Medical Director at DaVita Kidney Care. He is involved with the RPA as a member of the Board of Directors, Chairman of the Healthcare Payment Committee, and member of the RPA's team of advisors to AMA RUC Utilization Committee. He is a transplant trained at Vanderbilt University and got his MBA from University of Colorado at Denver. Dr. Terry Ketchershid's bio is longer than my biography, so in the interest of time, I'll keep it short. He serves as the Chief Medical Officer of Integrated Care Group at Fresenius Medical Care, co-chief of Interval Health, which is a physician-centric population health company focused on patients with renal disease. Terry has been a member of the board of directors of the RPA. Dr. Ketchershid earned his medical degree from UT Southwestern and an MBA with the Health Sector Management Certificate from Duke University. Welcome, both of you. All right, I guess they have nothing to disclose. Let's start with some poll questions. If you don't mind launching it, Steve. Just click on the answers and it should disappear. All right, so we have about 60% of the participants today who are participating in an ESCO. All right, second question would be, did you apply for a kidney care first model, comprehensive kidney care choices, both or neither? Perfect, so we have 46% participants who have participated in both, who have applied for both the models. Perfect.
Well, perfect. Oh, we got a third one. Sorry, go ahead, Nishant. My apologies.
Sorry. That's okay. For ESRD treatment choices, would you rather be opted in, opted out, and what is ETC? So most of us would wish we were opted out, although we don't know exactly what the dynamics of that would be. I think we have a few more slides, and I'll hand it over to Jeff. Let's see. All right, so Advancing American Kidney Health was an executive order that was written back in July of 2019. The goals of that model, of that executive order, was to reduce the number of US citizens who are developing ESRD by 25% by 2020, which is a pretty substantial target. And even a substantial target is 80% of ESRD patients should be initiated with home therapy or transplant by 2025. The goal, it was very heavy on home use and very heavy on transplant use. The last point, which is to restructure the payment models to incentivize incentivize prevention and incentivize transplant, was one of the big aspects of this executive order. Could we advance the slide, Steve? All right, this is nothing new. The value-based programs from CMS has been ongoing from early 90s. They have implemented different programs, and this is just a list of programs. CMS has a triple aim, which they have put out a few years ago in their planning, in which they wanted to push more and more of CMS dollars based on value care. So whether we like it or not, we have participated in value care models before, and we will continue at a much more aggressive. And today's presentation is all about different types of value-based programs. And with that, I will pass it on to Jeff to carry forward the slides. Perfect. Take over, Jeff.
Well, perfect. Thank you, Nishant. And didn't mean to step on your words earlier, but I feel like I'm preaching to the choir here when we talk about why we need value-based programs in the United States. And this is a little bit of a hard slide to look at, but just understand that we are completely different than our neighbors to the east and certainly to the south when we look at both European countries, but also even beginning to look at some of the South American countries and otherwise, in terms of our general life expectancy for the dollars that we spend in healthcare. And that really is quite evident when we look at spending for chronic kidney disease and end-stage renal disease, totaling $114 billion several years ago, and of course, increasing since then. And so this is, in my mind, the sort of reasoning behind why we need value-based programs, and especially within nephrology. About a year ago, it was almost exactly a year ago, I think it was July 9th of last year, the president announced his executive order advancing American kidney health. And Nishant has already provided some of those goals, increasing home dialysis, increasing transplant, and slowing the rate of progression of CKD such that 25% fewer patients will ultimately need dialysis over the next 5 to 10 years. And the way they did that is they looked at new regulations for renal transplant and OPOs and providing extra money for research and innovation, especially through KidneyX, increasing CKD awareness. And then, of course, what we're going to talk about today, the payment models, which are designed to incentivize physicians and large dialysis organizations in general and transplant organizations to slow the progression of CKD, to increase the likelihood that a patient could get either a preemptive transplant or a transplant at some point during the time that they have end-stage renal failure, and increasing the amount of home dialysis. And I think most of you are well aware of the voluntary models, given the fact that the majority have applied to either one or both of them, Kidney Care First or the comprehensive kidney care contracting models. And those are the ones we're going to talk about today. I'll spend some time talking about KCF, and Terry will talk about CKCC. The mandatory model, which is known as the end-stage renal disease treatment choices model, a little bit of an odd term since they call it treatment choices, but we certainly don't have a choice of whether or not to participate. The way it's designed right now, although it is on hold and so things may change before it is actually launched, is that 50% of the regions in the United States will be in the ETC and 50% will be out of the ETC. The biggest difference in terms of the mandatory models versus the voluntary is mandatory focuses primarily on getting patients to home dialysis and getting patients transplanted, whereas the voluntary models focus on chronic kidney disease care and then also on end-stage renal disease care as well. So let me dive right into KCF, and just in a nutshell, and I'll go deeper into all of these, but if you've applied to KCF, you already have a pretty good understanding of this. It changes the way that we as physicians are paid for taking care of patients with CKD 4 and 5 and for taking care of patients on dialysis. There is a modified capitated or partially capitated quarterly payment for taking care of our patients with CKD 4 and 5. So rather than charging for every single thing we do on a fee-for-service basis, we get a quarterly payment for that. There's also a modified payment for taking care of patients on dialysis. And then on top of that, there's a bonus or a penalty, which we'll discuss here in just a few minutes. So that can increase those modified payments or decrease those modified payments. We get a bonus for getting patients transplanted, and then it makes us eligible as well for the 5% APM bonus. Now, just to be clear, this is only a bonus or a transplant bonus or a penalty on our traditional fee-for-service Medicare patients. So patients that are in Medicare Advantage or patients that receive commercial insurance, they are not participating in these models. The way these payments work, the base pay for CKD 4 and 5 is a quarterly payment, and it's payment for most of what we do for these patients, although there are certain things that we can still bill outside of the capitated payment. So this is payment for our E&M services, transitional care management services, doing advanced care planning, if you do an annual wellness visit, or any chronic care management. It's all cohesive in that one $240 a quarter payment. If you do kidney disease education, CKD4 education, or certain other things, you can still bill for those on a fee-for-service basis. Now, for the modified or adjusted MCP, the way that one works is we get paid at the 2 to 3 patient visit level. So we don't get the highest reimbursement, the 90960. We get one level below that. But we're only required to see those patients once a month. So you can take a little bit of a hit, in essence, on revenue on the ESKD side, and that is in theory made up by higher revenue on the CKD side. And so the government's idea here is to balance and get us focusing a little bit more on CKD as opposed to ESRD. And then on top of that, there's a bonus for transplant, like I mentioned, only for your fee-for-service Medicare transplant patients. And in general, most of us get about 1 fee-for-service Medicare transplanted patient per year. So if you've got a group of 15, that would be 15 patients per year. Obviously, some areas of the country that's higher, some areas of the country that's lower. But in general terms, it's about 1. And it pays a pretty handsome bonus of $15,000 paid out over 3 years. And that's $2,500 the first year, increases the second year, and then increases again the third year, as long as that given patient keeps their transplant and that transplant is functioning. And within KCF, unlike within CKCC, which Terry will talk about, within KCF, all of that money goes to the general nephrologist. The patient is attributed to the general nephrologist, and that bonus goes to the general nephrologist. Now, all of this money, well, not the transplant money, but the modified and adjusted capitated rates for CKD and for ESRD can then be further adjusted upwards by even 30%, although I think getting the 30% number is going to be pretty tough, and I'll explain that in a minute, or can unfortunately be adjusted downward by 20%. And the way this works is a little bit complex, and I'll try to sort of simplify it, but if you're participating in this, you're definitely going to want to understand it in greater detail. The first thing is you have to make it through the quality gateway. And it's a pass-fail. You either are doing good quality of your patient care based on what the CMS considers quality, or you're not. If you are doing good quality, you're in for potential payment adjustment upward. If you're not doing good quality, you are out and you are getting your payment adjusted downward. And then once you're in, then the amount of payment adjustment upward, or even in some cases still downward, has to do with resource utilization, how much money your patients are costing the system. And this combination of this quality gateway and these utilization metrics lead to 8 different patient payment level, or not patient, but 8 different payment levels for your modified and adjusted capitated payments. So this gets a little bit confusing, but basically this quality gateway has to do with 3 quality metrics. First is what's called gains in patient activation, and this is a National Quality Forum metric. And the gains in patient activation rely upon a questionnaire, and it's about a 13-question questionnaire. I think there's some different modifications of it. And your patients score from 0 to 100, and then they're basically put into groupings based on that. And so if over time, every year, your patients are increasing in activation, meaning they are more involved in their own care, they have an understanding because they've been educated about their care, and they are engaged, then those numbers go up and you get credit for that. The second quality metric is depression remission, and this is based on that PHQ-9 questionnaire. And if patients are responding to depression treatment, then you get quality. And then the final one, which actually makes sense for us within the CKD realm, is controlling hypertension. And the NQF guideline there is for patients that have an ICD-10 code of high blood pressure, that they are controlled at a lower than 140/90. So if you make it through the quality metrics, then you hit resource utilization. And resource utilization, again adds a level of complexity, but it is the number of patients that start dialysis with an optimal start, so a preemptive transplant, starting dialysis with a PD catheter, or starting dialysis with true vascular access like an AV fistula or an AV graft. Hospitalization costs, and we know that our patients, especially our ESKD patients, spend about 1 to 2 trips to the hospital every year, depending on their comorbidities. And then you are also on the hook for the total per capita cost of these patients. Now, that only includes Medicare Part A and Part B. It does not include Part D, but you can imagine that Part A costs can skyrocket if patients are hospitalized regularly. So this is the general basic 8 levels. If you make it through the quality gateway and you're in the top 10% in terms of those resource utilization metrics I just mentioned, then you automatically qualify for a 20% bonus on those adjusted payments, which is pretty impressive. That's certainly not to be scoffed at. But it's also not easy to be in that top 10% of those KCF practices, because you imagine that the best of the best practices are the ones that join KCF. So you're already competing against the cream of the crop. On the other hand, if you have, if you're still in the good side of the bell curve, you may not get the 20% bonus, but you certainly get some type of bonus, and this is meaningful. Unfortunately, if you either don't hit the quality gateway, or if you do hit the quality gateway, but your expenses are higher than average, then you are either going to be neutral on payment, which isn't the worst thing in the world, I suppose, or unfortunately, you're going to take a hit in payment down to a negative 20%. But I mentioned that you could actually hit a 30% bonus. And I'll be very honest, and this is my opinion only, Terry can certainly disagree with me. I think it's going to be nearly impossible for anybody to hit the 30%, because what you have to do is not only be the cream of the crop, that top 10% already, but then year over year, you have to improve by another 3% on resource utilization. If you were to do that, then you get the 20% for being in the top 10, and then another 10% for year over year improvement, which would hit you 30%. I think that's pretty unlikely. What could be a little bit more likely, however, is maybe you were in the 4th or the 5th group, so you were getting just a small bonus, but you did have year over year improvement. You could see your bonus increased both because of where you sit on the bell curve, but also where you sit on continuous improvement. The duration of this demonstration is currently set to be 3 years. It was supposed to start January 1st, as you all know, delayed because of COVID to start April 1st. And we anticipate, and the government has left the door open, that they will increase the demonstration project another 2 years. So it could go through either 2024 or even through 2025. Most of you, since you have applied, have already found out if you're eligible. To be eligible, in essence, you have to be either a relatively large size group or you have to work with others in order to make up a large size group. Even if you don't formally join, you have to be in the KCF program together and have 500 Medicare fee-for-service patients that you see on a regular basis twice in the past 6 months. You also have to have 200, again, fee-for-service Medicare patients that you're taking care of from an ESRD standpoint. So I think I'm going to skip the next slide just in the interest of time, and we can go back to it if necessary. But I want to kick it over to Terry to talk about the other side of the voluntary models, CKCC.
All right. Whoops. Let's back up. There we go. Thanks, Jeff. I got the computer glitch. How about that? Good afternoon, everybody. Good morning. Thanks for joining. Thanks for the time. Jeff is very, very difficult to follow here. So let's start off talking about CKCC. CKCC is the what we commonly refer to as ESCO 2.0. These are total cost of care models. And like many of you who have applied, you understand that they start with the formation of something called a kidney care entity. We're going to have lots of acronyms. So a KCE. There are 2 requirements to put a KCE together. You need a nephrologist and you need a transplant provider. Everybody else is optional, including dialysis providers, although most believe that to operate this thing successfully, you'd be best suited if you had a dialysis provider at your side. There are some geographic restrictions, just like in the ESCO. You can't just go out and say, I want the entire state of Texas to be in a CKCC, for example. They have loosened the restriction a little bit, but it's still there, and they've been pretty firm about that. There are minimum patient counts, just like in KCF. There need to be 1,000 stage 4 and stage 5 Medicare Part A and B, A and their Part B premium CKD patients in order for this thing to have those minimum patient counts. It is a total cost of care without the drug spend, as Jeff pointed out. And interestingly, in CKCC, the professional payments to nephrologists are nearly identical to those in KCF. The big difference is that adjustment up and down, that PBA disappears. You kind of get what you see on the professional fee side. There are three different options we'll talk about in a minute. Each of them are distinguished by the level of risk that you're exposed to. So as a nephrologist, how do I get paid in CKCC? Well, interestingly enough, those first two, again, look identical to what Jeff just walked us through. For every dialysis patient in the model, you get the 2 to 3 visit MCP payment. And then for most of the work that you do typically on an outpatient basis for a late-stage CKD patient, you get this quarterly capitation payment, which confusingly is identical to the 2 to 3 visit in center. It's just that you get paid for a quarter instead of a month. The transplant bonus is still there, a very attractive feature. The KCE, however, is required to split that in a unique way. So the transplant provider that's part of the KCE must receive 20% of that bonus. The nephrologist in the KCE must receive 20% of that bonus. And then the KCE gets to decide what to do with the other 60%. The real difference, though, is what's at the bottom. These are total cost of care models, meaning if together you're able to reduce costs in the eyes of Medicare, you get a piece of that, you get to share in that savings. On the other hand, if you overspend, you will have the privilege of writing a check to Medicare. That we'll get to in a moment. Before we talk about how that's determined, let's just quickly roll through the three options. So from top to bottom, this is increasing risk. The least risky financial risk here is the graduated option. The graduated option is really modeled after the small dialysis organization ESCO. In fact, if I were going to try to do this without a dialysis organization, this is where I would land. If you do invite a dialysis organization to this particular party, they can only have 35 clinics. These are really, really small organizations. The other unique thing about the graduated option is there are 2 levels, and you get to elect which one you enter. You can start at level 1, you can start at level 2. Importantly, in all the models that Jeff and I are talking about today, except ETC, the level 1 graduated option is the only one that's not an advanced alternative payment model. And that's particularly of interest to nephrologists, right? If I'm a qualifying participant in an advanced APM, I'm excluded from MIPS and I collect this handsome 5% bonus on my Part D book of business. If you pick level 1 graduated option, that's not an opportunity for you. You'll do MIPS that year. Everything else is an advanced APM. If you pick the graduated option, you only get to stay in each level 1 year. So I get 1 year in level 1 and next year I have to go to level 2. And then after that, if I want to continue, I have to go into the professional option. Professional option allows you to take more risk. It says you're on the hook there for half of the savings and losses. That's not exactly true. All of these things have risk corridors in them. You're responsible for half of the first 5% of the savings or losses. The global option really does open up risk substantially. The global option says for the first 25% of savings or losses, I'm on the hook for all of it. That's a big deal. Last thing I want to highlight here is through the course of the model's time, whether it's out to 2023 or 2025, you can only move up in terms of risk. If I start in the global option, I'm in the global option. I can never step back to the professional option. If I start in the professional option, I can graduate to global. So if you're in a total cost of care program, one of the things you really, really, really want to understand is how are we being measured in terms of our financial performance. And the vast majority of that revolves around how they intend to calculate our financial benchmark. What is our financial target in terms of savings or losses? Now, I will tell you at a high level, this is better. Actually, it's hard to get worse than what they do in the ESCO. This is better. It's transparent. You can actually see what they're doing. There's a lot to like here. There are still some questions, though, that haven't been answered, and those questions need to be answered, hopefully, before anybody's ready to jump on board here. So the way this starts is just like in the ESCO, they're going to go back and look at your historical local claims experience, 2017, 18, and 19. overweight 2019, and they're going to combine that with something called the Medicare Advantage rate book, number 3 at the bottom. We think that's actually a good thing. Both of those are readily available. There's some things they're going to do to the rate book calculation we need to better understand, but that's okay. The other good thing is we can't, for the life of us, figure out how they're calculating trend in the ESCO. Again, it's another part of that black box. But in this model, they're going to use a publicly available trend factor, USECC, for both CKD and ESRD separately. And then we get to this slide. So you know how everybody on this call is taking care of the sickest patients? My patients are sicker than yours. Everybody believes that, and of course it's not true. The way to basically objectively figure that out is through something called risk adjustment. And CMMI recognizes they need to risk adjust the patients in these total cost of care models, but they're not telling us yet how they're going to do it. One thing they are telling us is they're not going to use the HCC framework, which everybody else in this country uses today. So we want to know, because let me tell you, risk adjustment is unbelievably important in these models. And then last but not least, there's an interesting way. They have to expose us to downside risk for this to be an advanced APM. And the way they do that in CKCC is they say, all right, we've calculated your benchmark. You're right here. Now, if you're in global or professional, we're going to say, you know, out of the gate, you get to start down here. We're going to lower that by 5%. We're going to create what we call a quality withhold. Now, you get to earn that back, but the way you earn it back is through the performance of those 4 quality measures at the bottom of this slide, which Jeff just walked through. Now, some of those make a lot of sense. The first 2, you know, in my experience, haven't been tested in our population, and we'll want to pay close attention to how they're going to measure us. What are those benchmarks? Because again, remember, 5% is a big, big quality withhold. All right, so these are the things that would keep me up at night. We'll get the answers as time rolls by. I wanted to just mention one thing. These slides will be available. We're going to race through them here. The ESCOs, all those of you, the 60% that are in the ESCO, your ESCO will have the option to extend PY5 by 3 months. If you wanted to just roll right into KCC without a gap, that option is up to you. There's some other options that you should pay attention to, but a little off topic for today. Jeff talked about the extension. So due to COVID, the important thing I will say is all of you know whether your application has been accepted, and almost all of them were. What that application acceptance means is you have an option. The option is I can start in April of next year, or I can defer until 2022. If you defer until 2022, you need to recognize you're no longer in an advanced APM. And so you'll get to do MIPS that year. If you start in April, you have a 3-month period of time where you're really not in an advanced APM. They made some allowances in the ESCO in terms of how they calculate what's called a qualifying participant. That is a critical calculation. The regular one doesn't work for the ESCO. The assumption is that we're going to go through this and become qualifying participants next year. If they make that change, I think all of us will be qualifying participants if we start April 1st. We got a 5-minute warning. I'm going to go right to this slide. Just a quick way to compare the 2 that Jeff and I talked about, the big differences, the way you get paid as on your professional fees. In KCF, exposed to the PBA, not so much, in CKCC, and then of course the total cost of care. This is the timeline. We're all, if we're going to go April 1st, in September, we'll see what's called an implementation performance period agreement. If you apply for CKCC and KCF, you can sign both of those. You're taking no risk. What that does is it turns on the claims feed. You'll know what your alignment numbers are if you've got enough CKD patients. You'll know what your benchmarks are, so you'll have some time to think about which one you want to join. In March of next year, you'll see the performance year PA. Don't sign that without reading it very carefully. That commits you to at least 2 years of risk. If you're on 2 different applications, you can only sign 1 performance year PA. And Sean, let me stop there. I know we're short on time, and open it up for questions, perhaps.
Perfect. Thanks, Jeff and Terry, for the wonderful presentation. So I tell you that we do have a few questions. the first question seems pretty simple, which is principal care management or chronic care management. I think it is included as part of the bundle payment. Terry, I'll start off with a question about the HCC risk adjustment that you mentioned. If they are not going to use that, do we have any idea what they're going to use for risk adjustment? Because that seems to be the holy grail of how they're going to figure it out.
Yeah, I wish I knew. We keep asking. They have set up a series of educational webinars. One of them is going to be about their financial methodology, and I suspect that's when it will be unveiled. But that's a big, big question, and we need to know the answer. I certainly wouldn't put my name on one of those without knowing that answer.
And Nishant, I think you brought up the chronic care management code, which is part of the global payment. So the chronic care management 99490 is, and Terry, maybe you know better than I do, but at this point, to my knowledge, they have not directly included principal care management in that chronic or in that capitated quarterly payment. That could change, certainly, but I think it is possibly a small loophole at this point.
Yep, you're exactly right. That's my understanding too, Jeff.
Yeah. Do you guys want to take a dig at, there's a question about private insurances, how they're going to react and what's going to be response from them?
I'll let Jeff handle that one.
Thanks, Terry. Well, first off, private insurance is, there's a gazillion, if that's a technical term, different private insurance out there. And obviously there's the big ones, United Healthcare and Cigna and items like that. I would say just in general, and Terry can probably would agree with this, they want to lower the total cost of care for dialysis patients as well, which is, high on their priority list due to the books that they have. But to my knowledge, they have not, at least in large numbers, come out with big capitated global payments like this, and we will see.
I agree more, Jeff. It's interesting, a number of those payers are hiring people that have worked at CMMI, though. I don't know if you're seeing that, but I've come across that.
There was a question about there is quite a bit of money up front for practices. And do you think that ultimately participation with these models would be there without major changes because of the upfront cost?
Yeah, I'll speak first. I think it's a great question. I mean, one of the things that I wonder about in KCF and CKCC is, somebody's going to have to go collect these new quality measures and then turn around and report them. And those measures, at least in the nephrology practice I know of, nobody's doing PAM surveys, nobody's doing PHQ-9 surveys. So yeah, there's an upfront investment. I think most practices are going to weigh that against, the opportunity cost of NIPS, perhaps. That 5% bonus is pretty attractive. And that transplant bonus is, that's almost certainly, they picked that up from the RPA model of care, I think, that many of us were involved with.
Well, thanks for the answer, Terry. I think we are at the 12:05 benchmark here at Central Time, at least. So thanks for the wonderful presentation. We have one or two more questions, which I think because of lack of time, we won't be able to answer, but the presentation would be made available live. For more details on this, go to the RPA website, and also for COVID-19 related, we have COVID-19 Hub on the RPA website. Thanks for all of you for participating. Have a wonderful day and stay safe.
Thanks, everybody.
Thank you.